Hello friends, so continuing with our hip examination series, what we are going to discuss today is we are going to discuss about the salient concepts of hip examination as far as the measurements are concerned. Okay, so we are not going to discuss about the basic measurements like wasting and all. We are going to discuss about the challenging and confusing concepts as far as the measurements are concerned. Okay, so what our plan for today is what our plan for today is we are going to discuss the Bryant's triangle in detail with the concept. We are going to discuss the various lines like Nelaton's line, Shoemakers line, Chienes line, and Morris by trochanteric line. And we are going to discuss the concept of true and apparent shortening in detail. And at the end, the part which I am most excited for is we are going to practice some numerical based real time cases, some cases which would require a little bit of hip examination knowledge, a little bit of reasoning, a little bit of logic, and a little bit of mathematics. Okay, so without further ado, let us begin with our today's session on the salient features of hip measurement. Okay, so we'll start with the concept of Bryant's triangle. Okay, so how do we measure the Bryant's triangle? One is by digital Bryant's triangle and the second is proper measurement. Okay, so the digital Bryant's triangle we measure by thumb, index finger and middle finger, and the proper measurement, that is what we are going to discuss today. So basically what is the purpose of Bryant's triangle? The purpose of Bryant's triangle is to know whether the shortening is supratrochanteric or infratrochanteric. Okay, now, what are the prerequisites? For measuring the Bryant's triangle? And commenting on whether it is supra or infratrochanteric, the first prerequisite is the pelvis should be squared. Now, secondary requisite is, so what is Bryant's triangle? We measure the difference in base, altitude and hypotenuse bilaterally over both the sides. Okay, so the other side has to be normal in order to get to know whether the affected side is having shortening of the base, shortening of the altitude, or it is the same. Okay, so it is only applicable for unilateral pathologies. Why? Because basically it is you have to make Bryant's triangle on both the hips and then you compare with the opposite side to get to know if there is any pathology. Okay, so basically we'll understand what a Bryant's triangle is. Okay, so this is right hip, this is left hip. Okay, so these are both anterior superior iliac spine. Okay, these are both greater trochanter. Okay, so how do we make the Bryant's triangle? So first things first, we mark the anterior superior iliac spine, we mark the greater trochanter bilaterally. Okay, then we join a line between ASIS and greater trochanter. Then what do? We draw a plumb line from anterior superior iliac spine towards the floor, that is towards the couch. Okay, and then what do? We draw a perpendicular line to the plumb line joining the GT. That is what forms the Bryant's triangle. So we compare bilaterally the measurements of Bryant's triangle. Okay, so this is the base, that is from superior to inferior. The mediolateral part is the altitude. Okay, and the diagonal is the hypotenuse based on the Pythagoras theorem. Okay, so this is base, altitude and hypotenuse. So what do? We compare the measurements of base on both the side, we compare the measurements of altitude on both the side, and we compare the measurement of hypotenuse on both the side. Okay, so that is bilaterally, that is how we compare. Okay, and based on the measurement, it gives the clue to clinch the pathology, whether what is affecting, whether it is the femoral head, whether it is the neck, fulcrum, or the acetabulum. That is how it will give a clue to clinch the pathology. That is what we are going to discuss in detail in the subsequent slides. And most important, it lets you know if there is any supra or infratrochanteric shortening. Okay, so the schematic flowchart. So first things first, the most important measurement is we check the base. We check the base. Okay, so if the base is decreased on the affected side, what does that mean? Okay, so if this part is decreased on the affected side as compared to opposite side, what does that mean? That shortening is in this region, so it is above the greater trochanter. Okay, it is above the greater trochanter. So as soon as a patient presents with limb length discrepancy, there is let's suppose right limb shortening. Okay, so there is let's suppose there is true shortening of 2 centimeters. Okay, now you compare the Bryant's triangle on both the sides. So let's suppose if the base is shortened by 2 centimeters, so you can say that it is 2 centimeter supratrochanteric shortening. Okay, that is the true shortening. Okay, so if the base is decreased on the affected side, that indicates it is supratrochanteric shortening. And if the base is equal on both the sides, what does that mean? That the shortening might be infratrochanteric. Or there is no limb length discrepancy. Okay. Now moving forward, we are going to discuss the individual parameters and what does that signify. Okay, so first things first, we are going to discuss about the base. So whenever the base is decreased, whenever the base measurement is decreased as compared to opposite side, don't forget, as compared to opposite side. That is why we do measure it only in unilateral hip pathologies. Okay. So the basic crux when base is decreased is GT has gone proximally. That is the basic concept. Okay. What does altitude indicate? We are going to discuss in the concept in subsequent slides. But basic concept of altitude is, if the altitude is same, that does mean that there is no rotational deformity and there is no medial displacement of greater trochanter. Okay. So what are the basic conditions that comes to your mind whenever GT goes proximally? So it could be a supratrochanteric shortening, it could be a varus deformity as well. Okay, so let us discuss about the various pathologies. Okay, so let us discuss all the condition in which the base is shortened. Okay, base is shortened. So it could be at the pathology at intertrochanteric region, which could be a malunited intertrochanteric femur fracture. It could be some pathology at the hip joint. Usually in all these pathologies, what happens is base is also shortened, at the same time altitude is also shortened. Like in conditions neglected hip dislocation, acetabulum fracture, girdle stone arthroplasty, excisional arthroplasty, all these conditions. Okay. It could be due to some pathology in the femur head, where the femoral head has collapsed, which causes supratrochanteric shortening, like dissection of femoral head, post-fracture, Perthes disease, all these conditions. And additionally in coxa vera also, there is GT going proximally. Okay, so that was the concept of the shortening of the base. The basic crux is GT going proximally. Okay, now moving further, so now whenever there is shortening of the altitude, so this is the altitude, that is the mediolateral distance from the perpendicular line to plumb line to ASIS. Okay, so what is the basic pathology? Just think of the thing. So either it could be some medial displacement of GT, okay, or it could be some internal rotation at the GT. So whenever the femur internally rotates, what happens is GT comes more anterior and medial. Okay, so whenever femur internally rotates, GT comes anteriorly and medially, and whenever the femur externally rotates, the GT goes more posteriorly and laterally. So any condition, so when does the altitude decrease? Either internal rotation of femur, that is femoral anteversion, or there might be a medial displacement of greater trochanter. In conditions like central hip dislocation, any pathology leading to the collapse at the hip joint, in which there is decrease in the base and decrease in the altitude both. So basic crux, what the basic crux of base was? Decrease in the base was, the basic crux of decrease in the base was proximal migration of GT, and the basic crux of altitude is internal rotation of the femur. It is femoral anteversion or some medial displacement of the femur due to hip joint collapse. For example, central hip dislocation. Okay. Now, when does the hypotenuse decrease? So it could be due to shortening of base or shortening of trunk or both. Basic Pythagoras theorem. Okay, so hypotenuse could be decreased in all these conditions wherein there is shortening of the base or shortening of trunk or both of them. Okay. Now some interesting conditions. In conditions where base and altitude both are decreased. So when base is decreased, what does it indicate? That there is supratrochanteric shortening. GT is going proximally. Okay. And altitude is decreased, so it could be any pathology wherein there is internal rotation of the femur or medial displacement of GT. Okay, so both the components are there. So this is the proximal component, this is the medial component. So when in all these pathologies, when the vector force is in oblique direction towards the joint, in those conditions the base and altitude both will decrease. Okay, so what are the common conditions? Central hip dislocation, resorption of the neck, protrusio acetabuli, all these conditions, both base and altitude decreases. Okay, now moving forward, when does the base, this is a specific condition, when does the base decrease and altitude increase? Okay, so base is decreasing, what does that mean? Clearly GT going proximal, altitude is increasing. So what does that mean? That GT is, there is some external rotation of femur. Okay, external rotation of femur which causes GT going more laterally, which is increasing the altitude. Okay, so all the condition in which there is external rotation of hip, all these conditions along with the GT going proximally, all these conditions would have this kind of picture wherein the base is decreased and altitude is increased. Most common condition, anterior dislocation of hip. Most common conditions showing this kind of pictures are anterior dislocation of hip, non-union neck of femur, scaphy, girdle stone arthroplasty. So in anterior dislocation of hip, the lesser common presentation of dislocation of hip, there is external rotation usually, right? In non-union neck of femur, there is external rotation. In scaphy, there is combination of varus adduction and external rotation, and in girdle stone arthroplasty. So all these conditions wherein the GT is going proximally due to the collapse at the femoral head, neck or the hip joint. But at the same time, the hip is going in external rotation, which is increasing the altitude. Am I making sense? Okay, so these are specific conditions which might be asked. So anterior dislocation, non-union neck of femur, scaphy, all three are very specific conditions. Okay, now in deformities, in the coxa vara, as we discussed, GT goes proximally, so the base is decreased, while in coxa valga or magna there is lengthening of base, altitude or hypotenuse. Okay, so that was the whole concept of Bryant's triangle. Base is based on the GT going proximally, and the altitude is based on the axial deformity of the femur. Okay, so that was the concept. And where do? We only do where we are able to square the pelvis, and only in unilateral pathologies of the hip. Okay, so this is the basic crux, the concept of Bryant's triangle. Okay, moving further, we are going to discuss about a very interesting concepts of the various lines to determine the various levels of GT and the shortening. So without further ado, let us begin first with Nelaton's line. Okay, so this is the schematic diagram. This is umbilicus, this is midline. So we are going to follow this protocol for further slides and lines. Okay, so this is bilateral anterior superior iliac spine. This is the ischial tuberosity. And this is the greater trochanter. Okay, so Nelaton's line is always taken in lateral position. So you flex the knee and the prominent point, you mark the ischial tuberosity. So normally, as I've shown in this figure, normally what happens is the ASIS and ischial tuberosity line, the line joining ASIS and ischial tuberosity, it crosses the tip of GT. Normally ASIS ischial tuberosity line intersects the GT tip, but if the GT tip lies above the Nelaton's line, so it is, what does that indicate? Indicates that there is some proximal migration of greater trochanter. I repeat, how do you take the Nelaton's line? Remember the positions. Remember the position you take in lateral position. You flex the knee because you have to mark the proper ischial tuberosity. So ASIS IT line normally intersects GT tip. If the GT tip lies above the Nelaton's line, what does that indicate? Indicates the proximal migrated greater trochanter. Okay, moving further, we'll understand the concept of Shoemaker's line. Okay, so the same protocol, umbilicus, anterior superior iliac spine bilaterally, and greater trochanter. So Shoemaker's line is taken in supine position. So what is the concept? So we join the anterior superior iliac spine and greater trochanter. We join the anterior superior iliac spine and greater trochanter and extend it proximally. So that is what we do bilaterally. And normally what happens is, both the lines in which the bilateral hips are not affected, normally what happens is the anterior superior iliac spine GT line crosses at the midline and at or above the umbilicus. Okay, so that is the normal condition when, as you can see in the figure, so both the lines are crossing at the midline and at or above the umbilicus. Okay, so now let's suppose the GT has gone, is very conceptual, very logical. You don't need to mug up, just need to visualize, just need to imagine the concept. Okay, so let's suppose there is a pathology in which there is supratrochanteric shortening. The GT has migrated proximally. So right side as GT has migrated proximally, and the left, and so you join the lines greater trochanter to anterior superior iliac spine bilaterally. So left line is normal. Left line, as you can see, is normal. The left line is normal, but the right side, the GT has gone proximally. So what happens? As you can imagine, the line goes the greater trochanter anterior superior iliac spine. Due to the proximal migration of greater trochanter, the line intersects on the opposite side and below the umbilicus, because the angle decreases because of the proximal migration of greater trochanter. Okay, so normally what was happening, both the ASIS GT line crosses midline at or above umbilicus, but whenever there is proximal migration of GT, the Shoemaker line crosses opposite to the midline. That is what you have to remember, at the unaffected side, and usually they cross below the umbilicus, as you can see in this schematic diagram. Okay, so moving forward, what is Chienes parallelogram? Very simple, the name itself suggests parallelogram. You join both the anterior superior iliac spine, line joining both the anterior superior iliac spine, and a line joining both the greater trochanter. So normally they should be parallel to each other. But whenever there is proximal migration of greater trochanter, as you can see in the photo itself, as you can see in the diagram itself, it is converging over here. Both are not parallel. So in proximal migration of greater trochanter, both lines converge at the affected side, while whenever there is distalization of greater trochanter, both lines diverge at the affected side. Okay, so that is Chienes parallelogram. Very simple. And the last line is the Morris bitrochanteric line. So what do? You join a line from pubic symphysis to greater trochanter bilaterally and compare both these measurements. So normally both the lines bilaterally, the distance between the tip of greater trochanter and pubic symphysis should be equal. But whenever there is medial displacement of GT or some rotational deformity of femur, the GT goes more medially. So bilateral Morris bitrochanteric line would not be equal. So what are the common causes? As we discussed in detail in the Bryant's triangle, so it could be some central fracture dislocation, protrusive acetobuli, or all the conditions we discussed in detail in the Bryant's triangle. Okay. So that was the concept of lines. Quickly we'll revise. Nelaton's line. What is Nelaton's line? It is between, in the lateral position, it is between ischial tuberosity and anterior superior iliac spine. Great retrocenter ideally should intersect the ASIS IT line. If the GT is proximally migrated, it lies above the Nelaton's line. What is the Shoemaker's line? It is done in supine position. We join greater trochanter and anterior superior iliac spine bilaterally. Normally it should cross up at or above umbilicus at the midline. But if it is crossing on the opposite side, below the umbilicus, the affected side GT is proximally migrated. Chienes parallelogram, joining both ASIS, both GT ideally should be parallel. If it is converging, so remember this, it is converging on the affected side in proximal migration. Okay, that is Chienes parallelogram. And Morris bitrochanteric line from pubic symphysis to greater trochanter bilaterally, if ideally should be equal. Whenever there is rotational deformity or medial displacement of GT, it is unequal. Okay, so that was the whole concept. Of all the interesting lines which help you to clinch what is the pathology, whether there is supratrochanteric shortening, whether there is GT proximally migrated, or there is some rotational deformity of the femur. All these conditions we can diagnose, we can understand with the help of the measurements of these lines. Okay, now we are going to discuss a very interesting concept and logical concept of true and apparent limb length discrepancy or measurement. Okay, so first we'll go to basics. What is true limb length? It is the actual bony length with both the lower limbs in identical position. So what do I mean when I say identical position? So first things first, there should be squaring of pelvis is absolutely necessary, the prerequisite. Don't measure the true limb length before squaring the pelvis. And the second important thing, when I said identical position, so both the lower limbs should be in identical coronal orientation. So what do I mean when I say this? Let's suppose the right lower limb has 10 degree of abduction deformity. So to measure the true limb length discrepancy, you square the pelvis first. Okay, and both the limbs should be having identical position. So you even keep the left sided lower limb after squaring in 10 degree abduction to measure the true limb length discrepancy between right and left lower limb. Identical coronal orientation and squaring of pelvis is absolutely necessary. That is what you call the true limb length measurement. So there is no compensation at present. Because we have already squared the pelvis. Okay, so and then we measure from anterior superior iliac spine to medial joint line of knee, and from medial joint line to medial malleolus. Okay, so it could be segmental, we can measure segmental also. So this could be ASS to medial joint line is femoral segmental limb length measurement, and medial joint line to medial malleolus is tibial segmental limb length measurement. Okay, so femoral segmental could be supratrochanteric or infratrochanteric. We already discussed in the prior slides. Okay, now the further more interesting part is the apparent limb length. So what does apparent limb length indicate? It is the final resultant effect after the compensation. The basic crux line is this. Okay, so let's suppose there is coronal plane deformity of the hip. Okay, so the body compensates by pelvic tilt. ASIS is lower in abduction deformity, ASIS is higher in adduction deformity. All these we have in detail discussed in the previous video on our hip series. Okay, so what the purpose of the body is to make both the lower limbs parallel to each other, so that we achieve a bilateral plantigrade foot, after which we can ambulate. Okay, so apparent limb length, what is apparent limb length? It is after the body compensates for pathology by various mechanisms, by pelvic tilt, anterior superior iliac spine going upwards or downwards, and the resultant effect after the compensation, which is apparently seen, the name suggests, which is apparently seen in the patient when he is presenting. That is what you call as the apparent limb length. Okay. So what are the prerequisites? Both lower limbs should be parallel to each other, and squaring of pelvis should not be done. Squaring of pelvis should not be done, because we want the resultant effect after the accommodation. As soon as you square the pelvis, the body compensation is gone. So we square the pelvis in true limb length discrepancy. And we keep both the lower limbs in identical coronal orientation. While in apparent lower limb, what we have to do is we have to keep both the lower limb parallel to each other. So you tug both the lower limbs, you make both the lower limbs parallel, and you tug the lower limbs distally. Okay, so that is the concept. This is the concept of true and apparent limb length discrepancy. Okay. Now, the last part, the most interesting part, we are going to practice to boost the concepts of true and apparent shortening and coronal plane deformity. As I said, we have discussed coronal plane deformity in detail in the previous video of the hip practical series. Okay, so we are going to discuss some of the hypothetical situations which would require a bit of logic, a bit of reasoning, a bit of knowledge about hip examination, and a bit of mathematics. Okay, so without further ado, let us begin with our first question. So let's suppose this patient which is presented to you has right sided 20-degree abduction deformity, and apparent shortening is 1 centimeter. So you have been asked to measure what the true shortening is. Okay, so putting all the concepts in one place. So the patient has 20-degree abduction deformity. Okay, so what does that mean? That there should be 2 centimeter lengthening. Am I making sense? This you can understand from the previous video. So every 10 degree corresponds to 1 centimeter of limb length. Every 10 degree of coronal plane deformity corresponds to 1 centimeter of limb length discrepancy. So abduction deformity causes lengthening of lower limb as a compensation, while adduction deformity causes shortening of the lower limb as a compensation. Okay, so 20-degree abduction is there, so 2 centimeter lengthening should be there. Okay, but the apparent and resultant is showing in the patient as 1 centimeter shortening. Okay, so you have to logically analyze what is the true shortening, what should be the true shortening. So even after 2 centimeter of lengthening by compensation, still apparent is showing as 1 centimeter shortening. Okay, so what should be the true shortening? The true shortening should be 2 plus 1, that is 3 centimeter shortening. Understanding this retrograde. So this patient has 3 centimeter of true shortening. Okay, 3 centimeter of true shortening. But due to the 20-degree abduction compensation, the limb has lengthened by 2 centimeter. So the resultant is 1 centimeter of apparent shortening. So that was the question. Am I making sense? Interesting. Am I making sense? This is very interesting. Okay, so 3 centimeter shortening was there, 2 centimeter got lengthened by the coronal adaptation, coronal compensation, which caused the resultant 1 centimeter apparent shortening. Okay, so apparent shortening is the final result when the patient presents. True is the bony deformity, is the bony shortening. Okay, am I making sense? Okay. So now proceeding with the next question. Let's suppose this patient has 30-degree of adduction deformity. Okay, and the apparent shortening is 2 centimeter. Now tell me what is the true limb length discrepancy. Okay, so the patient has 30-degree of adduction deformity. What does that indicate? That there would be 3 centimeter shortening by compensation. Okay, now the resultant effect which is shown in the patient is 2 centimeter of apparent shortening. Okay, so what should be the true shortening? So you have to analyze that even after 3 centimeter of shortening by compensation due to the adduction deformity, the resultant apparent is 2 centimeter shortening. Okay, See, what should be the true limb length discrepancy? It should be 1 centimeter. It should be 1 centimeter lengthening. Am I making sense? Am I making sense? So let's I'll explain it to you retrograde manner. So there is 1 centimeter lengthening. Okay. Now due to 30-degree adduction deformity, there is 3 centimeter shortening. As a result of which the apparent shortening is 1 centimeter lengthening minus 3 centimeter shortening is 2 centimeters of shortening. Am I making sense? Am I making sense? Interesting? Very interesting? Yes? Okay. So proceeding further. Let's suppose the third question, the patient has 10 degree of adduction deformity. Okay. And the true shortening is 2 centimeter. Now we have to measure the apparent shortening. Very simple. 10 degree of adduction deformity. What does that mean? There would be 1 centimeter of shortening. Plus there is 2 centimeter of true shortening. So what should be the apparent resultant effect? The resultant effect is 3 centimeters of apparent shortening. Okay, and the last question for the session. So this patient has 20 degree of abduction deformity with true shortening of 2 centimeters. So now I am asking you to measure the apparent shortening. So let us discuss the answer. There is 20 degree of abduction deformity. So 2, because of which the compensation there would be 2 centimeter of lengthening. Additionally, there is 2 centimeter of shortening. So what would be the apparent shortening be? The apparent shortening would be 0 centimeter. So apparently the resultant limb length discrepancy in which the patient presents is 0 centimeter, because the shortening of 2 centimeter is being compensated by lengthening for the compensation of 20 degree abduction deformity. Okay, so these were the 3 to 4 questions we discussed. Now I have 2 questions for you. You have to solve these questions and answer me in the comment section or the social media page, which I'll mention in the subsequent slides. I want to know the answer, whether you have understood the concept or not. Okay. So that was all about the salient features of hip examination measurements, all the confusing and challenging concepts. That is what we discussed today. I hope you found it useful. I would love to get your feedback in the comment section or in the social media page. So this was Dr. Mihir Tejura signing off with hip examination measurements simplified for you. You can check out the other videos on hip examination and some more videos on orthopedics simplified for you. Thank you so much, guys.